Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, and welcome to another episode of the Skin Sync podcast. This is one of your hosts, Shannon Moranti.
And this is Bucci Nita.
Today, in today's episode, we are going to go through the hurdles that are often associated with medication access and getting our patients the medications that we want to prescribe them. Not what's necessarily always on their formulary, not necessarily what the pharmacist has on their shelf, but actually what we, the dermatology provider, think would be the best medication for that patient. I know it's so incredibly frustrating for so many dermatology providers out there to learn about all these fabulous new medicines and go to a conference and get so excited to prescribe something the newest, latest, greatest. Yet we don't always know how to find it, how to get it. And it's often the first thing we ask our drug reps, yet it's the last slide in the drug rep deck. It's almost as if it's kind of buried in the background of the evidence. So Bucci, do you echo my frustration? Are you also at that place where we're so frustrated and trying to get patients the medication that they deserve?
Absolutely. It is extremely draining. I would say it's even kind of demoralizing sometimes because it did not used to be this way. I've been in practice 15 years. You've been in practice, 23? And I think back in the day, we came into dermatology with paper prescriptions. We'd
Oh
literally
my
write
gosh,
our
do you
prescriptions
remember
down
that? Like your
on a
old school
prescription pad.
prescription pad?
Yes, it was fantastic. And I think the most we had to do back then was maybe provide the patient a copay card if we knew it was a branded medication, but it was really that simple. And things have really transitioned significantly over the last many years. How did we get here, Shanna? Like why did things change? How did we get to this point?
It's so frustrating to remember, like literally watching that paper prescription walk out of the office and never having to think about it again. Yet now I feel like as soon as I explain the medication and the side effects and the benefits and do all the documentation, the very next number of minutes are spent on, oh, okay, well, now we're going to have to tell you where you can get that medicine. You can't just go to your friendly pharmacist anymore. I always say friends don't let friends use Walgreens because
Yeah.
unfortunately some of these big box pharmacies just really are going to try to give that patient whatever is on their shelf. So if you want specialty medicines, sometimes patients are going to have to go through specialty pharmacies. I know in Florida, we use specialty pharmacies all the time. How about in Atlanta? Is that a pretty common practice in
It's
Atlanta?
pretty much standard practice for us. I mean, if we're
Yeah.
writing brand name medications and oftentimes even generic medications, we are using these partner pharmacies because we know it's going to reduce the number of phone calls we have. We know that the likelihood of patients getting the drug that we're prescribing is increasing. So we really make it kind of a standard in our practice.
Yeah, for sure. I feel like at first there was a lot of resistance, especially for my older patients. They didn't understand that a pharmacy would be calling them. So I definitely try to tell those patients, hey, like, here's the phone number. When you get to your car, reach out to them so that they are making that initial contact or save that pharmacy phone number in your phone right now while you're sitting here. So it's not just some unknown number that'll get blocked by your phone. So I do definitely always recommend utilizing specialty pharmacies and really promote it for patients so that we have a better chance of getting them the medications that the patient deserves.
Absolutely. So Shanna, I wanted to kind of go, a little bit into the details about like who is responsible for this. Like why are we having these issues getting these medications? Is it the insurance companies? Is it the pharmaceutical companies? Is it the
Yeah.
pharmacy
Who's to
benefit
blame, right?
managers? Kind of tell us who is to blame because someone needs to be, it's not us. So
For
who's to
sure,
blame for
for
this?
sure, because it's certainly not your friendly germ
Right.
PA. No, it's such a frustrating system, and unfortunately, we have so many patients that come in angry because they pay very good money for insurance. They pay high insurance premiums, and yet most patients have no idea what's on their own formularies. They really do not know what they signed up for. Maybe they just signed up for the benefit at work and didn't go into the specifics of what level of coverage they actually got. So although patients sometimes want to come in and blame the pharmaceutical industry for their very high prices and or blame the insurance companies for not allowing them to get the drug, unfortunately, it often falls in the lap of this kind of middleman that's in the middle of the whole drug scheme. And that middleman is called the pharmacy benefit manager, the PBM. About 3 PBMs control about 80% of the drug market. And this is not small business. They actually make about $315 billion annually by getting these clawbacks, by getting reimbursements from insurance companies, basically for saying no to the patient's prescription rights and saying, no, you can't have this. You have to try what's on our very, very limited formulary. A lot of drug companies are trying to do their best. They're trying to offer incentive programs or programs that are kind of a coupon card or what have you, saying if your insurance company will only cover X amount, we'll cover the rest. So a lot of the cost of the drug can come out of the drug company's pocket, which unfortunately does not bode well for future research and development of new
Right.
drugs. So it is a very confusing system. And it's a system that, like, most patients don't know about, most providers don't know about. So it's almost like taking a little peek behind the curtain of the Great Wizard of Oz and kind of trying to figure out, like, who exactly is this great wizard and who is making all these decisions. And, they're a little bit like pharmacy mafia, I feel like. So if I go missing after this call, definitely look up all the PBMs because they may be to blame.
And the worst, one of the worst parts of all of this too is that they have certain rules, right? And we try to abide by those rules and then they change the rules just out of the
Right.
blue all of a sudden. And now you've got to kind of reset and try to figure out, well, how do I approach this next? It's not
Yeah.
sustainable. It is definitely a moving target. It is very frustrating. And there's a lot of
So,
potential, harm that can come from this, which we'll get into shortly. So thank you
yeah.
for kind of explaining the PBMs. Now I kind of want to talk about one of the barriers that they do create for us, which are prior authorizations or PAs, the bane of our existence in clinic. And these exist for a reason, right? So if we're looking at the positive side, right? These companies, these insurance companies oftentimes are trying to prevent non-approved uses of therapies. They maybe want to help prevent the potential harmful medications and interactions that can happen with certain medications. And then at the end of the day, it really is about their bottom line. These companies want to help control costs and really protect that bottom line.
For sure.
However, this creates a process for us that is, again, exhausting, it's draining, it's dangerous for a lot of situations. And I'll give you a story a little bit later, but there's a lot of negative outcomes that come with these prior authorizations. So number one, it just really creates a barrier between, right, the drug that we want the patient to have and them actually getting what we prescribe for them. So that's very frustrating. And patients oftentimes, when there's that barrier becomes really great, they will abandon their treatment. They will just forget about it. They don't want to have to go through this
Right.
process with us. So that means leads to potentially worsened diseases, right?
Absolutely. We don't want our patients to suffer from acne, which can eventually lead to scarring and
Exactly.
hyperpigmentation, or atopic dermatitis, which can lead to lost sleep and even a
Exactly.
decrease in childhood development because we can't get them on the proper medications.
Right. And then, of course, how does it impact us as clinicians? It's burnout, right? We are exhausted. We're trying to see a
Right.
full schedule of patients every day, and there's very limited time to try to get these authorizations done. At best, you have a trained team that can help you with it, but it does create increased burnout, increased workload for us, and of course, increased cost to the practice. Like, we don't get reimbursed to do these prior authorizations. We don't get paid anymore by the insurance companies to hire staff to do these prior authorizations.
So
So
true.
it's not reimbursable. It's very frustrating. And again, it can potentially be dangerous. I'm going to just tell a little story about a patient I had recently, just this last couple weeks, with very severe HS. I wanted to put him on a biologic therapy. The health plan would not cover that biologic, but they were willing to cover one of the biosimilars. Great, let's go put him on a biosimilar. And so, but I want to play their game, right? So let's just put you on this
Sure.
medication. Hopefully it'll help. And of course, now they want us to do prior authorization for the biosimilar. And at some point, there was some glitch in this process where they denied the medication. This patient happened to have Medicare. And I don't know if you knew this, I just learned this recently, but if you have Medicare, you've got one shot to get that prior authorization done and get it approved. If you do not get that drug approved with that one prior authorization, that's it. You have to do an appeal, maybe get a peer-to-peer. It just increases that length of time that the patient can't get their medication. And this poor
So
guy is
frustrating.
draining and oozing and having horrible pain. And he's messaging me every day on the portal and calling the office, and he's miserable. And I'm thinking about him constantly. I'm like, he's going to end up in the hospital if I don't do something quickly. So we ended up putting him on a branded, we had samples of the medication. The company has a great patient assistance program. So he's slowly improving. But I mean, what a horrible process. And if something were to happen to that patient, who takes responsibility for that, right? Will it be
Right.
the PBMs? Will it be
Right.
the insurance company? So just kind of one example of how dangerous it is really when we have to go through these processes for these medications.
It's so frustrating, but I think that we, as dermatology providers, we need to use stories just like this to fuel our drive to try to, like, fight for our patients, because
Right.
sometimes our patients don't know how to fight for themselves. They're miserable. They're calling us miserable. And sometimes they can be pretty nasty when they call us. I would be too. If I was that miserable, I would be saying, what is going on? Why can't I get this medicine? If it's for my child, why can't my child get this medicine? So sometimes we can actually put the onus on the patient and say, hey, look, contact your insurance company, start the prior authorization, because
Yes.
patients can actually start their own prior auths. And then we can kind of add in the medical info, maybe add in some information on what is actually FDA approved for this condition, why, patients should not be on another medication because it could lead to worsening outcomes like infection and what have you. And then truly hop on a phone and get on a peer-to-peer call and use our brains, use our knowledge and use our knowledge of the sequelae of the condition to help that provider, who may be a dentist by all means, or a
Right.
gastroenterologist or something totally unrelated to derm, but they will hopefully be enough of a big hearted clinician to understand that patients need to be well cared for. So hopefully this can fuel our drive, for our patients.
Absolutely, because we really wanna put up that fight, and it's not fair to us, it's not fair to the patient, so I think it's worth the fight. So I wanted to kinda get into some of the reasons for why we're getting denied. Why are we getting denials for these medications that we're prescribing?
I was gonna say, because if we can avoid, those denials, if we can kind of hurdle over those little tips and tricks and figure out exactly what we need to document appropriately the first time, it might make the prior authorization go by so much smoother.
Absolutely. One of the reasons, of course, is just coverage limitations, right? There's a lot of medications that are either on formulary or not on formulary. The patients, unfortunately, don't have a lot of knowledge about this, even though they do have access to get this information, but they don't have, they're unsure of how to go about that. But really trying to prescribe medications that are on formulary, which is something that is difficult to kind of, figure out. And unfortunately, the process of getting medications on formulary is really complex. So it's very hard to kind of understand, what drug you can and can't write for an insurance company.
Absolutely, and I don't know about you, but do any of your patients actually know what's on their formulary?
Very few, I would say maybe
Very, very
one
few.
patient per year that might know that.
Maybe. I mean,
Right.
and I have to admit, like, I'm a patient. I have my own policy. I don't even think that I know what's on my own formulary, and I work in this business. So it's extremely frustrating for patients when we say, well, hey, go find out from your insurance company what we can prescribe you. They get pretty mad about that.
They do. They
But
do.
there are ways of figuring out what's on their formulary, and sometimes we have to try and fill those first.
Exactly. Another reason that these drugs get denied, of course, is off-label use, which is really, I feel like it's half of what we do in dermatology. So it's really frustrating because
Right?
there is a lot of conditions that we treat that don't have on-label therapies, right? Granuloma annulare, lichen planus, morphea. There's a ton of things that we treat that have no FDA-approved medication, but unfortunately, that does create issues. So if we're trying to prescribe a therapy that is off-label, that is going to create a problem. Ideally, if you are writing for a particular medication, whether it's topical or systemic, you do want to make sure that you're using it for its FDA-approved indication. You want to be mindful of the age, appropriate age restrictions for these medications, if it's 6 and up or 9 and up or 12 and up. So that's something that's really important to keep in mind when you're
And
prescribing.
even generic medications or the generic of previously FDA approved medications will have an age indication. So, this is something I speak about in acne all the time. Generic tretinoin is FDA approved for 12 years of age and older. So if I get a PA denial, for a 10-year-old or an 11-year-old, one of the first things I say is, I can't use generic tretinoin. It's not FDA approved for that age. And then
Ah,
that helps that prior auth go through so much faster. So
I love
we should
that.
actually take the time to kind of learn some of those, even the generic age indications, because that can help your patients in the long
That's
run.
really great. Another thing is really reauthorization. So let's say a patient is on a current therapy, they're doing great with it, they're just following up for their annual checkup, and you want to make sure that they continue that therapy. You need to document how well they're doing with this medication. Like what's their improvement from baseline? Try to have some sort of a scoring tool, which we'll talk about shortly. But you really do want to make sure that you have evidence documented that this patient is doing well and should continue therapy. That's important for the insurance companies to know.
Do you think we have to document improvement? What if they're still struggling? Like, what if they're still frustrated? Is it important to show improvement in a prior authorization or in order to continue therapy? Or could it be kind of on par with where they're at, knowing that it can be a cyclical disease that doesn't always get better right away?
That's tough. That's tough because I have been in a situation where the insurance company denied reapproval of the medication because the drug's not working. They're not clear, so they shouldn't continue to be on this drug. So I've had a
Oh.
situation like that, and so that's a really tricky one. That's a good question, but I'm not sure, what the answer
So
is
we have
there.
to be careful of our documentation.
Right.
Don't just allow your MAs to go in and say, "Oh, they're completely clear," or their status have improved, or their status is well controlled if they're not, and make sure
Right.
that they're not changing the status the other way to say that it's worsening or something, because that may lead to a denial down the road. We have to be very careful with our documentation.
Absolutely. And so that brings us to our final reason for denial, or one of the many reasons is documentation. This is huge. And I
Yeah.
think a lot of us maybe underestimate how important this is. But a few of the things that we really should be documenting with every patient, particularly with branded medications. Number one, what have they tried and failed before? This is going to be for medications that you've prescribed or anyone else in your practice has prescribed for them, or what they've been on prior to coming to see you. It may be hard to kind of fetch these medications and find out the information because patients don't have a clue sometimes. What that pink pill, or I use that cream that was in the pink and white tube.
Yeah,
I
you
don't
know
know what
that
that
white
is.
cream, the one that comes in the tube? That
Right.
one. I use that one.
So what are some of your ways that you try to maybe get access to what those medications were that the patient tried and failed?
Yeah, I actually really try to gamify this for my medical assistants. I try to teach them, how important it is to try to get this information before I enter the room. If they are talking about any kind of rash, type of acne, any type of chronic condition that they have been using some sort of a treatment for more than a week or more, not just a bug bite that resolved last week that they used their hydrocortisone on, but what else have you tried? And if the patient's like, well, I got this cream, I picked it up at my local pharmacy. Awesome. Do you have an app for that pharmacy? In Florida, the state of Florida, Publix, a lot of these big box pharmacies will have their own pharmacy apps. And the patient will have that app on their phone because it allows for them to get easier refills on their medication. So they can very easily go in and look up their own pharmacy apps. Also, most patients will have access to their provider portals for their primary care physician or their pediatrician's office. So they can oftentimes access their portal and find out exactly what was prescribed and when it was prescribed, because it's important to know what they've used, but also how long they've used it. So this is information that I love giving my MAs, that high five or, hey, I'm buying you Starbucks today because you really did a great job figuring out exactly what they have tried. And you got the documentation and you put it into the note before I even walk in the room. So that way I know going in all the information that I'm going to need in order to make the best medical decision making for my patients.
Right. That's excellent. And there's another thing that we utilize in our practice. I don't know if you guys have something similar. Our EHR, you can actually access patients' prescriptions. You can actually see what they've been prescribed. Typically, it'll just give you a sense of what the drug was, dosing, and all of that. But that's really helpful. So maybe dig into your EHRs and see if you have access to that because it does kind of save you a lot of time. And then
Do
another
you have
thing that
Emma in your practice?
we do have
So
Emma. Yes. Yes. We
yeah,
do
so
have
you
Emma,
can
and Emma has that
import
tool.
yeah, you can import patient medications from the clipboard. So that's another
Yes.
awesome tip and trick. I'm so glad you do that. Basically, going over to that patient clipboard, so you kind of have to back out of the note on that day, but go back into the patient clipboard and actually import patient medications. Now, you have to get patient's permission in order to do so, but you can oftentimes import, and it'll give you all the information, all of their dosages and when they prescribed it, when they refilled it, etc. And sometimes the EHR can also show you the prices and what medications, may be on formulary. So we have to try to use those little tricks that are built into our EHR.
Absolutely. And then one other thing that you want to really keep in mind with documentation is there needs to be a scoring tool, some kind of scoring assessment in that chart note. A lot of medications are very specific to what they're approved for. Like, is it moderate to severe psoriasis, moderate to severe atopic dermatitis? And so try to have some level of scoring in that chart note. Is it a BSA that you want to have documented? Is it an IGA where you're documenting, mild, moderate, severe? Is it maybe an itch level? Is it a Hurley stage for an HS patient? Do you want to maybe use some quality of life measures? So try to make sure that you use as many of those scoring tools as you possibly can to kind of really give a clear picture of how severe that patient's disease is.
Absolutely. And where do you document those in your notes, Bucci? Because I'll sometimes put them into your status. Obviously, you can update your status for your IGA and for your itch scores and what have you. But sometimes I'll even can use the diagnosis comment button in Emma because it allows all that information to be right up at the top of that impression. It's actually in blue, it's almost highlighted. So it's very easy to find when you're filling out the prior auths later, or if you're having an AI system fill out your prior auths later. Where do you typically document all of that?
So I usually will use a status. I will actually document it into the chart note, like into my additional notes section. And then
Love
after
it.
attending your wonderful lecture recently at a conference that talked about access, I've actually been using that diagnosis, comment tool that
Yeah.
you recommended. So that's
Love
really
that
helpful.
diagnosis comment.
Yeah.
It's very, very helpful. And it really helps because you can put tried and faileds in there. You can put a lot of information up there, kind of right up at the top of the impression. Do you use any like sticky like checklists or any notes to pharmacist kind of like things that you can put into your actual prescription before you send it out to the specialty pharmacy? Because I have found that that also is very, very helpful. Saving a note, I oftentimes will save a note on my phone and I've transferred those to my MA's iPads. And then it has kind of all of the questions that they have to fill in, the tried and failed, the IGA, the itch score, exactly what age the patient is, if it's going to be used in special areas like genitalia or face or areas where steroids may not be appropriate. I found that that's a really nice tool that you can copy and paste into a notes to pharmacist before you send it out for the specialty pharmacy.
That's excellent. I've never used it with that level of detail. Oftentimes, I'll just put maybe the tried and failed therapies or make sure that I have the diagnosis in there. But that's actually really great. So thank you for sharing that tip because I'm definitely going to start using that.
Absolutely.
And then a couple other things. So let's dig into what are some other ways to get access to medications, right? How do we get these patients approved for these drugs? If I had my magic wand, every clinician in every office across the US would have a biologic coordinator. That would be
Oh my
my number
gosh.
one. I would love for
Fantastic.
that if I had a genie in a bottle.
Amazing.
That's my wish. So if you have a biologic coordinator, wonderful. We had one. We're
Treat them well,
treat
spoil
them
them
well. They are
rotten. At the same
fantastic. They
time,
are worth their weight in
they're worth
gold.
their weight in gold for sure.
If you do not have one, and then you do want to try to utilize what you have available to you, right? Train your team, train your MAs. You want
Yep,
to try to have a primary contact person for these biologics if possible, but try to train your MAs to kind of learn what to document in these chart notes. It also kind of falls onto the other office staff, right? The front desk. Are they getting the updated insurance cards? Because we need that. Are they getting updated demographics? Some insurance companies actually have the pharmacy benefit cards as well. So let's get all of that in the chart so we can send it off to the insurance companies when necessary. Teach your MAs to document as much as they possibly can, as much detailed, and kind of train them to have an ear for what to listen out for. My MAs with the atopic dermatitis patients, if I don't get an itch level in that chart note, if I don't say it out loud, they will chase me down until they get that information for me. It's a BSA
that's
for a
great.
psoriasis patient. They are so well trained to do that I don't even have to ask the question anymore. So
And those are becoming MIPS measures for a lot of our
yes,
documentation as
absolutely.
well. So we have to make sure that we're documenting NRS scores, which are your itch scores, any itis, any dermatitis, any
Yes.
rash in psoriasis. Make sure that you are capturing, PGA or IGA and itch scores and train your MAs to do so. If they don't hear you ask the patient, make sure that your MAs are asking that patient for those measures.
Absolutely. Make sure that those enrollment forms are completed and completed thoroughly in detail with all the signatures required because those little pieces are going to really be what makes or breaks your PA approval. Try to make sure that when you are doing a chart note, I like to use very disease specific or medication specific chief complaints. I don't know if you've used that in Emma, but
Oh,
oftentimes if
yeah.
you're using, let's say it's a specific biologic, type that into the chief complaint because it'll give you kind of an automatic drop down where you can kind of just click on, that history. And it's really detailed. It's really helpful. It'll prompt the MA to ask the right questions. And so try to utilize those specific chief complaints if possible.
And in that same vein, it's also really important to use the FDA approved diagnosis as the name
Yes,
of your impression. If
absolutely.
you are treating eczema and if your MA says, "Oh, they have had eczema or eczematous dermatitis, for years and years and years," your impression should be atopic dermatitis because these
Yes,
medications are not FDA approved for eczema. They're not FDA approved for eczematous dermatitis. They're not FDA approved for eyelid dermatitis. They're
yes.
FDA approved for atopic dermatitis. And if your MAs start going in and doing a DDX, oh, this could be contact, this could be allergic, this could be blah, blah, blah. All of a sudden, it's turned into
Yep.
dermatitis unspecified. And these medications are not FDA approved for dermatitis unspecified. So train the MAs or whoever's doing your documentation to make sure if it is actually an FDA approved impression of atopic dermatitis or non segmental vitiligo or plaque psoriasis or inverse psoriasis. Make sure we love to be splitters, but we kind of need to be a lumper in this regard
Right.
and call it by the correct impression.
Absolutely. And then another thing is that if there are contraindications to some of the more commonly approved conventional therapies, right, methotrexate or maybe, acitretin or cyclosporin, make sure those are documented in the chart note. If it's a patient of childbearing potential, if they've got a history of some contraindicated medical issue like hypertension, diabetes, alcohol use, make sure that's in the chart note, please.
Absolutely. You're so right. So we need to make sure that we are updating all of the medications every time that patient comes in, make sure we're keeping a running log of what medicines they're currently on so that there's not some archaic medication in the note. I've seen things get denied because they were on a medicine 2 years ago and it just was never taken out of the EHR. So, I think that there's a lot of really great options out there. Pharmaceutical industries now have some really wonderful patient access managers to help us. So if you are frustrated, please seek out some help in your local area. Talk to your reps and say, "Hey, I'm having trouble with access." Make sure that they can provide you with some support because maybe you don't have a ton of time. Nobody at the end of your very busy day to be doing and redoing work. We want to work smarter, not harder. We want to work efficiently and want our MAs to work efficiently to get the best outcomes for our patient. Well, Bushi, I think we have really kind of dove into some wonderful, wonderful tips and tricks on access. And I'm sure that there are so many amazing dermatology providers out there that will also have some ideas. So please add those to the show notes. If you have
Yes.
any other wonderful ideas that are working in your area or in your region, we would love to hear them. We are all in this together. You are not alone. You do not practice on an island and you have this wonderful dermatology APP community. So we would love to maybe do a part 2 and a part 3 on access just to kind of help each other out. Any last words, anything else that you can think of that we might have not talked about?
Yeah, really the last thing is you touched on this earlier, but get your patients to buy in, right? We're doing this for a reason. We want them to have these medications for a reason. Tell them why. Tell them why they need this over a generic medication and tell them what to expect, right? Are they going to get phone calls, maybe from the insurance, from the pharmacy, from the hub, from all these places? Make sure that they're answering that phone, emptying their voicemail inbox, right? So we can leave messages for them, use the patient portal
Right.
to contact us if they have questions, use the bridge programs, copay cards, but just get them to buy in because that really does help the process.
Yeah, we can only lead the horse to water. We can't make them drink. So we definitely have to have the patients buy in. And they might be contacted by the pharmaceutical, like field reimbursement specialists, or by, somebody who really does want to help them, by like a nurse manager from a company that really wants to help them get their medications in the most efficient way. So we need to make sure that the patients are aware that all of this help and support is coming their way. And they appreciate that. They appreciate we're going the extra mile to try to get them the best of the best. So
Yes.
I really feel like I learned so much from you. I always love picking your brain about these topics because we're all in this together and we really need to kind of have each other as advocates and have each other, have our colleagues be in their ear and be able to kind of share these wonderful tips and tricks. We will sign off for tonight, but we would love to do a part 2, part 3, part 12 on this issue, such an issue. So, but we're running a pretty bit long on time. So, Bucci, thank you so much for all of your amazing insights. And this is Shannon Ranchi signing off.
Bucina, thank you guys.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.